We're going to continue on our programming with some panel discussions. Session 1, the objective is to describe multi-level determinants of occupational well-being among healthcare workforce members from diverse and underrepresented backgrounds. Reminder that the multi-level determinants include individual, organizational values, and systems. And our three panelists today will speak to all of those levels. I'll discuss them each briefly. However, their bios are much longer than this and their contributions much more significant. Dr. Beverly Malone, known very well to the NAM Action Collaborative, is president and CEO of the National League for Nursing. She has been a leader of that organization since 2007. With over 20 honorary degrees and numerous accolades, Dr. Malone's distinguished career has blended policy, education, administration, and clinical practice. It's worth noting that in 2024, the American Nurses Association named Dr. Malone as their Hall of Fame Award recipient. She will be our first speaker, and our second speaker who will be joining us virtually, Dr. Justin Bullock, is a fellow in nephrology at the University of Washington School of Medicine and co-director of the Docs with Disability Initiative. He is passionate about creating safe environments in medicine where everyone in the hospital is able to bring their authentic selves to work in the spirit of healing. He is a passionate medical educator, teacher, researcher, and lifelong learner, and his primary research focus centers on how educators can minimize identity threats in the learning environment. And last but not least, Dr. Vivian Bradley Johnson is the Senior Vice President of Clinical Services at Parkland Health in Dallas, Texas. She oversees pharmacy, radiology, respiratory, clinical dietary, physical medicine and rehabilitation, and laboratory services. She has spent 39 years providing healthcare services to the underserved in Dallas County. In addition to her role at Parkland Health, she serves on the ASHP Board of Directors and also contributed to the ASHP Racial Diversity, Equity, and Inclusion Task Force. So with those brief backgrounds, we'll turn it over to Dr. Malone.
Well, colleagues, I feel inspired. After hearing that keynote, it puts a lot on each one of us to behave ourselves in a different way than we normally do, to understand that it's time to pass the baton on to others and that we have to stand up and speak out, show up and show out. And so I'm honored, privileged to be with my colleagues, and I'm grateful to be here. And I want to talk about a systems approach, but I want to say that I look at it kind of differently. When people speak of systems, sometimes they're only talking about the higher level system. And when I think of a system, I think of the individual level, the dyadic level, the group level, the family level, the organizational level. So I see us as not having the luxury of saying at what level of the system are we going to stay at. I see us needing to look at all those levels, and for somebody to have their fingers, their tentacles into various levels. And if we're going to really talk seriously about integrating DEI and well-being. So I'm a psych nurse extraordinaire, and a licensed clinical psychologist also. So this issue has been ruminating around, and I've been Black for a little bit of time. This issue has been ruminating around in me for quite some time. What I figured out is that each one of us, we need a North Star to be heading toward to keep us on track of when we're trying to put these things together. It's so easy to get distracted. It's so easy to be discouraged that we need something to look up to and to understand, am I on the path or did I step off? Did I get lost in terms of understanding how my well-being affects the patient care that I deliver? So my North Star is that well-being and DEI, or well-being and for the patient and well-being for the nurse or the provider, two sides of the same coin. You can't have one without the other. So it's not that the staff go first and then we do patient care. It's not that the patient just goes first. I do believe that all roads lead to quality patient care. And that, for me, that means that we need to get ourselves in order to make sure that whatever we're doing, it has, when we look at the outcomes that are going to be talked about, patient care should be the qualifying, should be the way, the dashboard that says that we're making a major difference, should be at least one of the primary values. So, underneath, if we have a North Star out here, the question then becomes, what do you have to pin it up? And I would suggest some core values. I like caring, integrity, diversity and inclusion, that I consider to be one thing, and then excellence. The definition for caring is promoting health, healing, and hope in response to the human condition. So we're caring with our patients, I hope everyone is, but we should be caring with ourselves too. And when hope is not there, did you hear that hope in there? That's when people commit suicide. That's when things go awry, when there's no hope around. So hope has to be part of the package. It has to be part of the formula. And the question is, who brings the hope when you're working in a unit, on a unit or in a hospital? Who's going to, and I suggest that we as providers, that we as professionals should have a self-generating mechanism of hope with us most of the time. If I don't have it, I need to talk to my colleague, one of you here, like Tim Brigham, and say, Tim, have you got any hope with you lately? I bet Bev Malone could use some hope today. And Tim said, I got plenty today, girl. Yesterday I didn't have any, but today I've got some hope. That's how we help each other along this journey. Not all of us will have hope at the same time, but it's how we work together on that. So caring, promoting health, healing, and hope in response to the human condition. The second one is integrity, and there's not a lot of, we're in DC, you know. Respecting the dignity and moral wholeness of every person without conditions or limitations. There's a psychologist named Carl Rogers. It's called the Rogerian theory of unconditional regard. That means that every person I work with, I have some regard for them. Regardless of who they are, what they are, whether I like them or not, I have regard for them. The third one is diversity and inclusion, affirming the uniqueness of and differences among persons, ideas, values, and ethnicities. And I have to admit that probably I do not like people who disagree with me on a regular basis. I think I'm right most of the time. And so this issue for us, especially professionals, it's a lot, diversity has more to do. When you add different ethnicities, different races, you bring different ideas. You bring different values, and that is as much of the issue as anything else. Then excellence is like the culmination of all of those, and it's co-creating and implementing transformative strategies with daring ingenuity. I really like that definition. But the truth is you cannot have excellence unless you have the others, those other three that I mentioned. So I said, my colleague introduced me and she said we would provide you with some stories. So I have a couple of stories I want to run by you very quickly. First one is, I was a director of nursing at a university hospital. Yes, they let me onto the floors. And I was new, and so I'm a little bit arrogant. I guess you figured that out by now. And I was saying what all I could do, what I was going to bring to the role. And so someone took me up on it. And they came to me and they said, there's a doctor, he happens to be an OBGYN, and he's told us not to touch his black patients. What are you going to do about it? We are talking well-being here, aren't we? I said, So my office was quite a few blocks from the actual place of work where the physician was. And so I took my time and thought about it and hoped I would have an answer by the time I got there. Nothing did come to mind, but by the time I got there, I knocked on the door and the gentleman let me in. And I said, Dr. So-and-so, it's my understanding that there is this rumor going around that you have been telling folks that, I can't believe it, but no, that you've been telling folks not to touch your white patients. You told the black staff not to touch your white patients. I know you would never do that, but I just want to tell you about the rumor. And he looked at me and he said, I would never do that. I said, I knew you would not. So, colleagues, sometimes we have to find ways to talk to people, especially when they're not thinking. And we have to do it in a way that we maintain their whatever dignity they have. And so they can still function, because all of us have errors. All of us have biases. Just because I'm black doesn't mean I'm not biased. I was raised at the dinner table just like some of you. I heard everything. And so we absorb those things. That's implicit bias that's built into us with some outrageous, of course, very outdone bias. But we are all not totally wrapped tight in terms of this issue. So that was the one I wanted to bring you. But I got a second one I want to bring you. And that is, I was a clinical nurse specialist in a university hospital, and I would get called for all kind of wonderful things. Anybody who had problems could call me. I wrote my own job description, so they gave me the entire house. And so they called me one day, and they said, we've got an issue on the neurology floor. It's only 20 beds, so would you go up and see what's going on? So I did. I went up, and the nurse manager said to me, I wasn't Dr. Malone at the time. She said, Miss Malone, we have a problem here. I said, well, tell me about it. That's what I do. I work with problems. And so she said to me, we have this issue where 2 staff members are not able to work together. I said, okay. I said, how long has this been going on? And she said, 3 years. They're not speaking to one another. I said, I beg your pardon? On a 20-bed unit, you got 2 people who are not speaking to each other? She said, yeah. But what I found, colleagues, we're talking systems here. The entire unit was divided right down the middle. And one of them happened to be a licensed practical nurse, and the other happened to be a registered nurse. So not only did we have issues of differences, but this was role differences and levels. And my goodness, the LPN was black. I know you didn't know it. And guess what? The RN was, any ideas? White. So we had a black and white issue here of differences mixed with role issues of differences. And I said, well, the staff divided right down. She said, oh, yes. I found out that just like Moses divided the Red Sea, they divided the staff quite similarly. And that if you missed a day at work, somebody called you at home and said, girl, let me tell you what happened today. Because they were not talking to each other. Someone had to carry the story. And the staff volunteered on a regular basis. So I said, I'm brilliant, right? So I said, well, I'll set them down and I'll talk to them. And the nurse manager said, oh, you can't do that. I said, I beg your pardon? She said, oh, no, they may hurt each other. I said, but I'm a psych nurse. Throw a few chairs in the room. It gets me kind of going. She said, they may hurt you. I said, well, let me take my chances. So I took my 2 colleagues into a room and I closed the door. I said, how did this get started? 3 years ago. They didn't remember. They couldn't tell me, but they had everything written down. Nurses take everything but nursing notes. So they had everything written down about what the other one had said about them. So I said to my 2 colleagues, I said, well, how do you feel about professionalism? And both of my colleagues said, I pledge allegiance to professionalism. I said, well, then how do you feel about quality care? I pledge allegiance to quality care. Then help me with this. If I'm in a patient's room, you're in a patient's room, and your colleague is outside, and you need someone to help you turn the patient, you won't come in to help her? Of course not. I'm not speaking to her. Doesn't that affect professionalism? Doesn't it affect quality care? Oh, we hadn't thought about it like that. The all-important question, would you be willing to change? And my colleague said, keep talking. So I did. First of all, you don't have to love each other in order to work with each other. That is a myth. And I've seen it operate in a lot of hospitals and a lot of units. I've even seen it operate in faculties. I used to be a dean. I've seen that too. You have to love each other in order to work. No, it's not required. Secondly, you don't even have to like each other. Now, I know this is going to disappoint somebody here, but you don't have to like each other in order to work together. But what is required? You do have to respect each other. And if we are going to mix diversity, equity, and inclusion, if we're going to mix it into the whole process of well-being, we've got to respect each other, colleagues. That is non-negotiable. So when I told my two colleagues, they said, I said, do you think you can do it? And they said, well, we can give it a try. And so they did. And I have good news to report. They did very well at it. But the unit started to heal and get better, and it pushed out the nurse manager. I wonder, why is that? Because anytime you know someone who's a leader, who's not calling it, can't tell when the water is filling his or her lungs, something's wrong with their leadership. And as the unit got healthier and started to work with each other, integrating their differences and keeping patient care center, it pushed her out the door. So those are my examples to you, colleagues, that I do believe it is possible to put it together, but I believe wholeheartedly that basically it's about not loving each other, understanding we're all human and we have our faults and our biases and our prejudices. The question is, what are you going to do with it? Do you know you got them? Secondly, you have to make sure that we are working with each other in a professional way, in a respectful way, not loving, not liking, but with respect. Thank you.
Thank you so much, Dr. Malone. Now we'll move to Dr. Justin Bullock, who is joining us virtually.
Are you able to hear me?
Yes.
Okay. Hello, everyone. I'm very sorry that I can't be there in person, but excited to join you all virtually. Once again, my name is Justin Bullock. I think I have three stories I want to share with you all, and I hope that they'll connect very nicely with what Dr. Malone just spoke about. And to orient everyone, I specifically want to focus on the intersection of ableism and licensure. I am I'm a physician. I'm finishing my training. I'm a nephrology fellow. And I also live with bipolar disorder. And in particular, I identify as someone who has very active, ongoing bipolar disorder. I've been hospitalized multiple times during my medical training. For me, feeling safe in the place that I work is essential to my well-being. I must feel safe to let people know when I'm not well or when I'm struggling. And so I have three stories. The first two kind of go together, and then I have a third one that I'll add at the end. So this time, and I guess to give you all a warning, I'll talk about my mental health journey. I'll mention suicidality. I don't go very deep into it, but if you need to step out or take a break, I just wanted to warn you and let you know that I would do that. So back when I was an intern, when I was starting residency, I was warned by my doctors about the risks of doing night shifts. That sleep dysregulation is very well documented to lead to mood dysregulation in bipolar disorder. And, I had always sort of done very well in school and even through medical school, and I thought that I would be able to make it through. I disclosed my bipolar disorder to my program as I started residency. And about halfway through the year, I had a period where I rapidly shifted between nights to days, nights to days. And pretty quickly, I became very unwell. And I ultimately attempted suicide. This happened outside the hospital. Everything within work had been going really well. But when I was in the psych hospital, I happened to be hospitalized at the same institution that I train at. Along the way, I encountered a provider on the inpatient psych side. And as sort of my care progressed, it became very clear that my outpatient providers and this provider and myself, that there was a big conflict that was happening, that we were sort of going back and forth and having a lot of tension. And my outpatient providers felt like that I was lying to them, et cetera, all these things. And it wasn't actually until months later, after I was out of the hospital and eventually had returned to work, that my own doctors actually found out that this provider, their license had been under probation, that they had previously been deemed to be impaired while at work, and were working on a provisional license. And at that time, as a person who was on the inpatient, as an inpatient, when you're on the inpatient psych side, you lose all of your ability to make your own healthcare decisions. And oftentimes people are not believed. I remember saying a lot of things that I've heard my own patients say to me about my providers not believing me. I really felt actually very infuriated at the medical licensure entity that how could they let this person who they knew was potentially impaired and through as I sort of got more information, I knew of trainees who worked with this person, and soon after I was cared for by them, they were no longer allowed to work with trainees or see patients on the inpatient side. And so I felt very sort of not protected by the state medical board, which was supposed to protect me. And I kind of wanted revenge. I was very angry. I felt very harmed. Um, and then transitioned to Justin as he would try to return to work. I did an outpatient program, and when I came back, I found that I faced immense, very powerful structural barriers that were really threatening whether or not I would ever be able to get to practice medicine again. That even though I had never had any work issues and that all my mental health things had happened outside the hospital, I had to do multiple drug tests, a personality test, had to disclose all of my personal sort of history, like every trauma that I've ever had, of having a history of sexual abuse as a child, like, all these things. And this was despite having outpatient providers who were caring for me and who had cleared me multiple times to come back to work. Um, and I share these two stories to really highlight the fact that I believe that providers there's no one who cares more about licensure than providers with serious mental illness because we find ourselves harmed on the patient side when people aren't safe to practice medicine, and we're harmed on the provider side when we're over policed and over regulated. And these things lead to very real consequences in the workplace. At this my at When I was at the institution that I had a lot of issues with, and I had an episode of hypomania, I told my doctors, and I was getting treatment through my doctors, but I didn't tell my work. Um, and for me, that actually felt incredibly unsafe. Um, but I also believe that telling my work was incredibly unsafe. And they had shown that I might lose my license if I was not perfectly well all the time. Um, so, through this time, I've done a lot of advocacy and speaking, and I'm actually right now working on a writing piece. And through this piece, I've gotten to interview a lot of directors of different state medical boards and physician health programs, programs which are supposed to support, physicians, with physical, mental, substance use disorder, issues, and help to either return to work or to evaluate to make sure they're safe to work. And one of the things that's come out very strikingly clear is that these physician health programs and licensure very much approach disability from the medical model. And the medical model basically says that disability is a problem inherent within the person. That to fix the disability, you fix the person. That is something wrong with Justin. That Justin's brain doesn't work well, and we need to fix Justin. And instead of thinking about disability, there's this social model, which thinks about the ways that the social environment actually creates disability. That while yes, I do have, and there's the dynamic model, which views from the both, and I really sort of adhere to the both for both. So yes, Justin does have bipolar disorder. I do have a tendency to have these mood episodes, but also the work environment that I work in, they knew that I had bipolar disorder, and they still had me work nights. And they're a healthcare system, and so they certainly should know that nights can be disruptive to people with bipolar disorder. And so if we look at those two things together, instead of holding all the accountability to the individual, if we actually had some structural or systemic accountability, where if we see that many people are struggling within a given place, that means that there's something wrong with that institution of the way that we're doing medicine, the way that we're having trainees train, instead of only looking at faults within the individual, I think we would make a much more healing medicine. Um, and the sort of the tag-on story of why I think this really matters is because I know unequivocally that me being bipolar has made me a better clinician. I have many identities. I'm Black, I'm gay. All of those identities help make me the physician that I am. But I would say my bipolar in particular, there's something very dehumanizing about having providers who don't trust or believe you. and for people to reduce you to your illness and not see the human that you are. And because of my experiences, I really try to attend to these things in my work and my care for patients. And I'm a kidney doctor now, but it turns out that people with kidneys also have brains, and those brains also get mental illnesses. And I've had so many meaningful opportunities. I think one of my first fears was I worried that my patients would not want to be cared for by me because I have bipolar disorder if they knew. And I have this Docs with Disabilities sweater. And one day I was in clinic and there was a patient who has pretty bad anxiety and who needed a kidney biopsy. And so I was sort of talking her through the kidney biopsy process. And she looked over my sweater and she said, "Oh, what's your disability?" And I said, "I have bipolar disorder." She said, "Are you going to be doing my biopsy?" I said, "Do you want me to?" And she said, "Yes." Um, One of the things that I found, I've actually never had a negative interaction after disclosing this topic of bipolar disorder. And I guess the last point that I want to leave everyone with is, we talk about, Dr. Malone mentioned professionalism. Um, I would say that in the professionalism that I have come to know, we often consider it unprofessional to bring our personal lives into the medical care that we provide. But I would say, to me, that's the most humanizing, the best way that we can provide care for people, is learning how to do things like disclose in thoughtful, productive ways, to not do it all the time, but to do it when we feel like it will be clinically meaningful. And I've just found so many opportunities to do that in real life. So thank you very much for listening to my stories. I'm excited to go next.
Okay, our last speaker is Dr. Vivian Bradley Johnson.
Good afternoon.
Good afternoon.
Thank you for that warm welcome, and I consider it a privilege to be here with you today. The experiences that we've heard today from Dr. Malone and Dr. Bullock, it just reminds us how important this topic is today and how much more work we have to do. As a healthcare workforce, well-being impacts, as we stated today, not only our personal and our professional lives, but also the lives of those whom we care for. And really, that's what's important, okay? If we're not well as healthcare workers, we're not able, as you've heard today, we're not able to provide excellent care. I'm going to offer you insights as a senior leader at Parkland Health, a Black senior leader at Parkland Health, and I'm responsible for a diverse healthcare work group. So I'm going to be talking about the well-being and diversity and equity inclusion through my support of individual employees and Parkland, the organization, and what I have committed to as a leader on a national level as an ASHP board member and a member of the ASHP Task Force on Racial Diversity, Equity, and Inclusion. First, let me just give you some information about Parkland. I don't know how many of you are familiar with Parkland, but Parkland is a public hospital in Dallas, Texas, and we have about 878 beds. We have 16 community primary care clinics within the community. We care for the homeless. We also are responsible for correctional health services as well. And our mission is to advance the health and well-being of the underserved and underfunded Dallas County residents. And from an organizational perspective, we actively work to shape our workplace culture. At Parkland Health, we're not there yet. However, we've adopted a very comprehensive approach to promoting occupational well-being among our staff. And this is reflected in our core values. Dr. Malone talked about it. Our core values include integrity, compassion, collaboration, accountability, respect, and equity, better known as I Care. Parkland's I Care values are the guiding principles for fostering a positive work environment. So you've heard some examples today. So in my allotted time, I'm going to share a few examples of how we are addressing multi-level determinants of occupational well-being with the workforce from a diverse and underrepresented background. And then I'm going to close with what I'm doing and what ASHP is doing to address this issue. First, let me just give you an example. This is a true case. Dallas was scheduled for to experience an ice storm. All the public schools were closing, but the hospital census was up. We needed all the employees to show up for work. So an employee called me. This was a single mother who called to say, I would like to come in, but I have no child care. Having to worry about your child care when schools are closed due to inclement weather or having a sick child can be stressful. So those things, as a healthcare employer, we need to be concerned about that. So what Parkland has right now, it's called Annie's Place. Annie's Place is a nonprofit that we actually partnered with to provide care for our patients' families, so that when our patients come for chemotherapy infusions, they can leave their children to be cared for while they receive their treatment. Well, we were doing that and it helped our patients. We saw that our absenteeisms, our no-show rates decrease. So we said, if it's good enough for our patients, why can't we make that available to our employees? And we are. And I must tell you that it has worked out so well, so much so that we have seen a decrease in our absenteeisms by employees, and we now are seeing that we're being asked to actually expand. We've gotten approval just last week to expand the capacity so that more children can also, of our employees, can be placed there whenever there's a need. So just knowing as a parent how comfortable you must feel knowing that you have someone that you trust caring for your children. So that's something that we've done at Parkland. Also, having an employee to decide whether or not to go in and be cared for. We need a healthy workforce. And believe it or not, we've had employees that would say, I can't go and have my mammogram because I can't afford to take off from work. So, you know, you work for a healthcare environment and you can't take off without having to take the entire day. And some of our employees, as we said, they're from the underserved communities, and taking off impacts their pay. So one of the other things, we had our employee health center several miles from the hospital. So it was very difficult for our employees to go for lunch and be cared for and come back. So I'm proud to say that Parkland now has a breast health center that is on campus. We also have our employee health center that is on campus, and we've established a program where employees can actually go and be cared for during their lunch breaks. They can have a mammogram. They can go and have lab work done. And we've been able to see our patient satisfaction or employee satisfaction scores go up as a result of these programs that we put in place. And the last story I have is COVID-19 pandemic. We've all been impacted. And it was the catalyst to change. We had a paradigm shift, and I'm going to say I did also. I mean, I always felt that as a pharmacist, you had to be at the bedside. You had to be on the healthcare team to actually provide services. But we found that during COVID, that was not possible. Our employees were stressed because we needed them to come to work. And so what we found that we had to do, we actually did. We implemented telehealth, and we were able to actually start providing more, essential services were provided by our radiologists, our primary care physicians, pharmacists, and even our nurses by having the telehealth program. And even today, we are continuing to look at remote work. Our job descriptions are being evaluated because there may be jobs that are still amenable for being a more remote type of employer. So we are continuing to do that as well. And again, as an employer, we've seen an improvement in our employee satisfaction because of these practices and changes that we've put in place for our employees. Now I want to turn to an organizational level. We have our own Office of Diversity, Equity, and Inclusion, which has been instrumental in providing resources to support the well-being and belonging of our employees. Our Parkland Office of Talent Management, they keep us in line because every interview panel must have diverse interviewers. Also, we are intentional and we have awareness about historically Black colleges and universities. I'm a graduate, a proud graduate of an HBCU, Florida A&M University. We are also engaged in the communities. So we are focused on learners in the community. We feel that it's important to actually go into the community and bring back students to train at Parkland. That helps us to become more competent of the disparities in that population, and so that has worked. We also are very concerned about the physical and psychological safety of our workforce. We believe that it is critical that when employees come that they feel safe. And I don't know about at your institution, but we've seen an increase in workplace violence. And I must say, we have been very fortunate to have the Parkland Sparks team. Sparks stands for Supporting Parkland Staff. This is a peer support program for employees who volunteer to provide confidential support to coworkers who experience a stressful adverse event, such as sudden death or medical errors. And the staff are trained, and we have seen also, prior to COVID, over a 5-year period, we had 702 contacts. Now we're up to 1,500 contacts just with this program. So it has really been successful. We've also implemented a workplace screening for our visitors. If you come in, you must be screened. And now employees feel very safe knowing that we have that. Just like what was mentioned today, the underserved and underrepresented employees, like everyone else, we want to be respected. They want to have their voices heard and be valued for their contributions. So I must say our Office of Diversity, Equity, and Inclusion has been instrumental in helping us to do that. The last thing I want to talk about is actually what ASHP, the strategies we've done at an ASHP or national level. The leadership and advocacy on a national level are also very critical. ASHP and its members have long been committed to eliminating racial and ethnic disparities in healthcare. In June of 2020 is when we implemented the ASHP Task Force on Racial Diversity, Equity, and Inclusion amid the national racial and social injustice that we saw. The task force was asked to actually just look at what was ASHP doing at that time to address disparities and to make sure that we were ensuring that the members were feeling belonging. And I must say, again, we have now implemented several programs whereby we are doing advocacy. We are also giving scholarships to the underrepresented universities so that they can also be a part of doing studies for helping us to reduce disparities. As I conclude, I want to thank everyone for giving me this platform, for discussing what Parkland is doing and what we're doing at a national level in ASHP to address disparities, to address DEI, and the well-being in the workforce. Thank you, and I look forward to questions during the panel discussion. Thank you.
I'd like to thank all of our panelists for their thoughtful comments today and giving a framework and then real-world examples of how you address these as core values within your institution. We'll look forward to hearing from all of them again during a longer Q&A session after session 2.